Good evening, everyone, and welcome. Bienvenidos a todos. Thank you for joining us for this virtual UHealth International Medical Series presentation, Advances and Innovations in Hematology Oncology, Lymphoma, Leukemia, Stem Cell Transplant, and CAR T-cell therapy. I'm Ileana Bravo, health journalist for UHealth. And this features today distinguished oncologists from UHealth, University of Miami Health System, and Sylvester Comprehensive Cancer Center. We're proud to announce that Sylvester Comprehensive Cancer Center is the only cancer hospital that received the National Cancer Institute designation in South Florida. And we want you to know that our experts are ready to take care of your patients in one of our 5 Florida facilities for in-person consultations, second opinion consultations, or even via telemedicine from the comfort of their home. To refer a patient, we invite you to contact UHealth International at 305-243-9100. by email at uhealthinternational@med.miami.edu, or of course by visiting uhealthinternational.com. Well, tonight it's our pleasure to hear from 3 experts who will share the most recent advances in hematology oncology therapies and how they can be used to help you provide the very best care for your patients. So let me introduce our 3 expert oncologists from Sylvester tonight. Dr. Craig Moskowitz, who will present diffuse large B-cell lymphoma. We need to catch up to the science. Dr. Namrata Chandok, who will present acute myeloid leukemia and myelodysplastic syndromes, advancing the field. And Dr. Denise Pereira, who will present stem cell transplant and cellular therapy recent advances. Now, during the presentation, we will poll you, the audience, on topics relevant to each discussion. Now, your responses are going to be anonymous. Don't worry about that, but we do encourage you to participate. You will also have the opportunity to ask our panelists anonymous questions throughout the presentation using the Q&A feature, and that's at the bottom of your Zoom screen. Take a moment to locate it. You'll see the Q&A 2 thought bubbles, and all you have to do is enter your questions as you think of them, and our panelists will address them at the end of the presentation. So let's begin with our first speaker this evening, Dr. Craig Moskowitz, the Deputy Cancer Center Director and Physician-in-Chief Oncology Service Line at the Sylvester Cancer Center. He is Professor of Medicine at the Miller School of Medicine, University of Miami Health System, where he oversees cancer-related clinical care, clinical research, faculty mentorship, advanced practice providers, as well as the Protocol Review and Monitoring Committee. Prior to coming to the Sylvester Comprehensive Cancer Center, he practiced at Memorial Sloan Kettering Cancer Center in New York for 26 years, where he directed the Division of Hematologic Oncology and had an endowed chair in lymphoma research. He has mentored 24 clinical researchers who care for patients with lymphoma and leukemia and are currently practicing at various institutions in the United States. As an international expert in lymphoma, Dr. Moskowitz's research focuses on improving the outcome of patients with poor risk Hodgkin lymphoma and diffuse large B-cell lymphoma and mantle cell lymphoma, incorporating molecular and radiologic imaging models. His therapy focuses on the use of new drugs, including targeted therapy, checkpoint inhibitors, antibody drug conjugates, and cellular therapy. His research has led to changes in standard of care that include the use of the most widely used salvage program ICE chemotherapy, PET adaptive therapies, maintenance therapy post-ASCT, utility of clinical and molecular derived prognostic models in the relapsed and refractory setting, and the incorporation of novel immune-based approaches in the second-line setting. Tonight, as we said, he's going to present on diffuse large B-cell lymphoma. We need to catch up to the science. So Dr. Moskowitz, it's all yours.
Well, thank you for that kind introduction. I appreciate everybody taking some time to hear these 3 talks. I know I will learn something from the other 2 speakers. I decided to focus on diffuse large B-cell lymphoma for a variety of reasons, the least of which it's an ever-changing field with rapid expansion in the science. It's by far the most common hematologic cancer, more common than all leukemias combined. As you're well aware, we do pretty well with this disease. About 2/3 of patients are cured with their first treatment. We've been giving R-CHOP now for close to 20 years, and it's about time that we try to move on if we can. It's been a difficult task, but we need to identify strong clinical biomarkers to inform our therapeutics. So unfortunately, there are so many negative studies. Let's begin. This is the first, we studied this at Sloan Kettering. It's called the Goya Study, which was R-CHOP versus CHOP with obinutuzumab, a second generation anti-CD20 drug. Fairly straightforward, one-to-one randomized study with the goal that the investigational arm would have an improvement in progression-free survival. Technically, we gave more antibody in the investigational arm with obinutuzumab than rituximab. I don't have time to discuss that, but it was an issue. At the end of the day, one can readily see that these curves are superimposable, and it's very clear that obinutuzumab did not and has not been approved for diffuse large B-cell lymphoma. Next, we were involved with the United States Intergroup, comparing standard therapy with R-CHOP given every 3 weeks, the dose-adjusted R-EPOCH, which was a program designed at the NCI, with excellent results from that center. This was a study that had prospective NGS sequencing done, although those results are still not yet totally available. So one-to-one random assignment trial for patients with bulky stage 2 disease, 3 and 4, with the goal of the investigational arm being superior. Many of us felt that this study may not even been ethical based upon the phase 2 data from the NCI. Unfortunately, these curves are superimposable. There's absolutely no difference between dose-adjusted R-EPOCH and R-CHOP. And dose-adjusted R-EPOCH is not given as part of primary therapy standardly in the United States. R-CHOP remained the winner. The third study looked at lenalidomide with the R-CHOP program. We call that R-squared CHOP. It sort of made sense to give lenalidomide, especially in the ABC subtype, I'll get to that in a few minutes, of large cell lymphoma. Lenalidomide exploits NF-kappa B and the cereblon Icarus pathway. There was phase 2 data to suggest from France that there was an improvement in survival with R-squared CHOP. There was a randomized phase 2 study done in the United States Intergroup, and then a randomized phase 3 study that was led by the GILA. And one can readily see, based upon independent review, that R-squared CHOP is no different than R-CHOP. So this is yet another negative study, and lenalidomide is not approved for in the management of untreated diffuse large B-cell lymphoma. Around the same time, there was single agent data in the ABC subtype of large cell lymphoma that ibrutinib had interesting response rates, up to 40%. And this led to a large industry-sponsored study called the Phoenix study, comparing R-CHOP 21 to R-CHOP and 21 with ibrutinib in patients up to age 80. Very complicated study. It was supposed to be blinded and randomized, but everybody knew who was getting ibrutinib because there was marked increased thrombocytopenia in one arm. And as you're well aware, R-CHOP does not cause hardly any thrombocytopenia. So we were hoping that based upon the preclinical phase 2 data, that the investigational arm would be a winner. Once again, it turns out, I mean, you can readily see that these curves are superimposable. Very disappointing. There was an unplanned subset analysis in this study looking at outcome based upon age. And for younger patients, we'll say younger patients are less than 60, there was both a progression-free survival and overall survival advantage to the R-CHOP ibrutinib arm. And I'll revisit this with you in a few minutes. It's unplanned, so it doesn't count in my book. And for today's purposes, these results are the same. Next, as you know, published 2 months ago in the New England Journal of Medicine was the POLARAX study. This was presented at the plenary session at ASH, comparing R-CHOP versus R-CHEP polatuzumab. Obviously, vincristine was omitted. 1,000-patient study. 184 were not eligible. And then there was a random assignment for the remaining patients to either get the investigational arm or R-CHOP. This is an interesting study. And in fact, if one looks at the curves, one could argue they look pretty negative. Their curve D shows no difference in overall survival. And if you look very closely to the curves, I don't know if my pointer comes out, you can see that there's absolutely no difference in outcome in the patients on treatment, so the first 6 months. That means there's no difference in primary progression. I've been studying this disease now for 30 years. If there's no difference in CR rate, there has never, ever been a difference in progression-free survival. For whatever reason, in this particular study, there was a difference in progression-free survival with a hazard ratio that met statistical significance. Not sure I believe the whole story. However, this is very likely to get approved. And I will come back to this in a minute to try to convince you that maybe it's not a positive study. If you look at the forest plot, once again, you're not necessarily supposed to do this when you're looking at the results of the clinical trial, but if you look straight down the forest plot and you look at cell of origin, there's absolutely no difference in the GCB cohort. And there's a marked difference in the ABC cohort. What's also interesting, in patients that are double or triple hit, there's actually an advantage to the R-CHOP arm. So it could be that the reason this study investigational arm is better, it was only better in the ABC subtype. And I will convince you that not all ABC subtype patients are the same in a minute. This is very hot these days. This is called time to initiation of therapy. The shorter it takes to treat a patient, the more likely the patient is going to be unfavorable. So you have a patient with significant lymphoma burden that is in the hospital and needs to be treated immediately and cannot even get a significant workup. That's much different than a patient who's outpatient who can get a full workup. So on the POLARx study, the median days to initiate treatment was 27. If you look at the data here in the curves on the left, if you're treated anytime after 21 days, there's almost a 15 to 20% improvement in progression-free survival with any treatment. And here in POLARx, it was 27 days. And in fact, in the POLARx study, both arms, the R-CHOP arm and the R-CHEP POLA arm, are both excellent. So basically, we have a host of negative studies. And what's happened? The problem has been is we have tons of science, and the clinicians can't catch up to the science. And the way I think about large cell lymphoma in 2022, it's really all about molecular profiling and modern imaging, if you have these things available to you, which we do have at our place. This is just a cartoon about straightforward sequencing of patients, which can be done from the blood, the tumor, or actually single cells. Usually we do not do that in lymphoma. You can look at circulating tumor DNA, regular DNA, or RNA. You can do a whole exome or whole genome sequencing or RNA-seq. We do FISH on all patients with large cell lymphoma. And now with NGS, we've been looking at certain types of point mutations. Based upon this information, we'll get a molecular profile, and in theory, there could be targeted treatment. This is all in theory. This is 20 years old now. We already know for 20 years there are 3 subtypes of large cell lymphoma: germinal center-derived large cell lymphoma, activated B-cell type large cell lymphoma, and an unclassified cohort. And we've been playing with this now for 20 years. It's clear right now that this model does not work to predict outcome in diffuse large B-cell lymphoma. In the subset of GCB large cell lymphoma, about 10% of patients have double hit. And double hit, as you know, means that there is a mutation in c-MYC with BCL2 or BCL6 or all 3. That is not the same as a double expressor, which just means there's protein expression of MYC, BCL2, or BCL6. Double expression has no impact on outcome in 2022, means absolutely nothing. Double hit, on the other hand, implies that we have rapidly growing disease. And pretty much these days, although based upon tiny data set, we give dose-adjusted R-epoch in double hit large cell lymphoma. It may very well be that this is not better than R-CHOP, but there's a lot of history behind this, and we tend not to give R-CHOP in double hit large cell lymphoma, and that's probably the answer to the boards. Give anything you want with an anthracycline, but not R-CHOP. This is where the money is. So this is data that comes from 3 groups. The first group is from the NCI, the second group is from Marburg in Boston, and the third group is from University College of London. Basically, we can take the ABC and the GCB subtype and the unclassified cohort, and we can divide them now into clusters. We like to call these, for now, we're going to call them clusters 0 to 5. And you can see that the ABC subtype falls into, the majority of patients fall into these 3 clusters on the top. And the GCB subtype fall mostly into the 3 clusters in the bottom, and the unclassified patients fall into various cohorts. If you look at the ABC subtype, it comprises pretty much about, give or take, 15 to 22% of the patients. The most common ABC subtype for today's talk, we're going to call the MCD subtype. This is basically the subtype where the BCR receptor is important, and there is overexpression of the NF-kappa B pathway. The N1 cohort is the cohort where Notch1 is overexpressed. These 2 cohorts may very well given us the answer in the POLARx study, because these 2 cohorts do extremely well with polatuzumab-based treatment. And it could have done so well that it made the study positive. We have to get more information on that. This is a better way of looking at it. You look at the left and you look at the diagnostic pathologic entities, DLBCL, NOS, the high-grade lymphomas, Burkitt lymphoma, PMBL, primary CNS lymphoma, and plasmablastic lymphoma. You classify them into one of these gene expression signatures. That's what we've been doing now. What we will be doing is classifying them into these clusters. If you look at the right panel, you can see that our best disease, PMBCL, falls into this group, which overexpresses SOXS1 and SGK1. The GCB cohorts, you can see, fall into the genetic subtypes pretty much of 1, 2, and 3, and the ABC subtypes fall into groups on the bottom. All of the primary CNS lymphomas overexpress MYD88. All the T-cell rich B-cell lymphomas, which is about 5% of lymphoma, we don't even know what's going on there. The same for the plasmablastic lymphomas. So what we're doing is we're created one disease, diffuse large B-cell lymphoma. When I started training in the 90s, it was one disease. 10 to 15 years later, we thought it was 3 diseases. Now probably it's going to fall into somewhere about 15 to 20 diseases. And if you look at outcome, it's very clear that the STK group, or the cluster 4, you can see that there are groups of patients that do terrible, especially those that overexpress Notch. I want to go back to the ibrutinib data. So it turns out that R-CHOP and ibrutinib actually does work. It only works, however, in the MCD cluster and the N1 cluster. It doesn't work in any of the other clusters. So if we had a patient and we sequenced the tumor and it's an MCD cluster patient, indeed, it would make sense to give R-CHOP and ibrutinib. That information is available at some highly specialized centers. I want to shift gears for the last few minutes. I don't want to run over just about PET and PET CT metrics. We're doing a lot of metabolic tumor volume work. It could be, I'll tell you how it's defined. It can also be defined by tumor lesion glycolysis, which is the product of MTV and the SUV mean. This is extremely important in 2022, and it will revolutionize the way we manage the aggressive lymphomas. For example, there are different ways to measure metabolic tumor volume. For the intensive purposes, we tend to use group C. We look at all PET sites that have 41% of the SUV max. We get a number. This is done pre-treatment. We'll skip this for a minute for time constraints. If your cutoff is low, probably no matter what you give, the outcome is going to be excellent. If your cutoff is high, R-CHOP is probably not the right treatment. More to come about this, but in multivariate analysis in many studies, it appears that metabolic tumor volume is more important than the IPI. So DLBCL is still our third best cancer after Hodgkin lymphoma and testicular cancer, but it is more complicated than ever. And I'm going to continue studying this until I'm too tired and can't take care of lymphoma patients anymore. This is our group at Sylvester, and I'll answer questions later, and we'll show my question that I gave you now.
Very good.
Let me stop the share.
Perfect.
Okay.
And that takes us right to our first poll question, as you mentioned, and that is interim PET is commonly ordered for patients with diffuse large B-cell lymphoma. Which of the following is true? And this is multiple choice. A, if a Deauville score is 4, therapy should be changed. B, if a Deauville score is 5, therapy should be changed. C, if a Deauville score is 1, 2, or 3, greater than 90% of patients will be in remission at conclusion of therapy. Or D, if a new lesion is seen, therapy should be changed. Let's give our audience a few minutes to answer, and we'll take a look at the results, and you'll weigh in, Dr. Moskowitz, and see how they did. Do we have that up yet?
I have to wait until let them answer it because it's a tough question.
Correct. We're going to give them a chance to think this through, and it should be on their screen, taking a look at it, right? There you go. All right, how'd they do?
I am impressed. The correct answer is C. We never change therapy based upon the results on an interim PET. And if a new lesion is seen, the answer is you have to do a biopsy. It's not to change therapy. So the correct answer is C. And the reason I never get interim PETs in large cell lymphoma because of those answers. Almost all oncologists get interim PETs because we are, in general, we're very nice people and we like to give good news. So if your interim PET is indeed 1, 2, or 3, you'll be giving good news. But the problem is sometimes you get stuff that you don't want that you have to kind of dig the answer. So I always get an interim CT. As long as it's improving, then I do a PET at the end of therapy. But I am very happy that people got that answer correct. I will take a break.
Yeah,
and we can move on. Okay.
I appreciate it. And so we have a small but powerful and mighty group that knows their stuff tonight. So let's tee up our next speaker, Dr. Namrata Chandok, an assistant professor of clinical medicine in the Division of Hematology at the University of Miami Miller School of Medicine, and a member of the Cancer Epigenetics program at Sylvester Cancer. She specializes in the care of patients with myeloid malignancies and has a long-standing interest in cancer biology with experience in clinical translational investigation. She's an active investigator on numerous clinical trials and is focused on the development and implementation of innovative cancer therapies. At Sylvester Cancer Center, Dr. Chandok spearheaded the development of a clonal hematopoiesis program to advance the care of patients who may be predisposed to the development of aggressive hematologic malignancies. Let's all welcome Dr. Chandok. It's all yours, Doc.
Well, thank you, Ileana, and thank you all for having me. I'm so glad to be able to talk to you. And now, judging the vast knowledge of the group, I feel like this might be easy, but I wanted to make sure that we're covering all levels. All right, so today it's just going to be a brief primer on acute myeloid leukemia and myelodysplastic syndromes, things that we know and things, the direction we're moving in, advancing the field. So just a brief introduction in terms of what the myeloid malignancies generally entail. So myeloid includes all cell types that come from a granulocyte. So basically neutrophils, eosinophils, basophils, also the monocytes, macrophages. It's a completely different lineage from what Dr. Moskowitz was discussing. And so within the spectrum of diseases, we have the myelodysplastic syndromes, acute myeloid leukemia, myeloproliferative neoplasms, and then overlap syndromes. Beyond this, there are also bone marrow failure syndromes, but today what I'm going to focus is on the first two, which is MDS and AML. And similar to what Dr. Moskowitz was saying, these are often packaged in like one disease and one problem, but realistically, it's a huge spectrum of disorders that span, the gamut. So where we start with for most patients is lab abnormalities. Acute leukemia may present with more acute manifestations, as the name suggests, but realistically, you're often presenting with profound anemias, consequences like bleeding.
Dr. Chandok, if I could just interrupt you for a quick second, could you
Sure.
put that in presentation mode?
Oh, I thought it is in presentation mode. I'm so sorry.
No problem. We'll follow along.
It's in presentation mode on my computer.
Okay.
I'm just going to unshare and then start once again.
All right. Not a problem. I think everyone can hang in here with us. Let's see while we get this going. Technical difficulties tonight, folks.
Thank you. Thank you for letting me know.
Yes, not a problem. It's such important information to share, so we want to make sure that it gets the.
Now does it look like it's in presentation?
There we go.
Perfect. I don't know what happened, but thank you for letting me know.
My pleasure.
All right. So where were we? We were talking about how patients are generally presenting. So typically lab abnormalities, occasionally these can be severe, but oftentimes just, a low hemoglobin that's otherwise unexplained, or platelet abnormalities, increased fatigue, bleeding complications. This is how patients present. And, frankly, this is something important to focus on, but patients frequently get put on iron or alternate supplementation without a true workup, or given a diagnosis of having a myeloid malignancy without the true workup. And this is a little bit shameful for, 2022. I frequently see this in my clinic from elsewhere, which is why I make it a big deal, but really to have a biopsy is the key to any of these diagnoses, because without knowing what the underlying pathology is, it's really difficult to figure out, how to proceed. Beyond this, for each individual disorder, diagnosis and prognostication is key, primarily because, even within these diseases, and I'll talk about this one by one for each of the two disorders I'm talking about, but the spectrum of survival is huge. So knowing what you're treating and how aggressive to be is very key, specifically since we're dealing with a huge, age disparity, and oftentimes older and more infirm patients. And then finally, of course, based on this treatment. So let's start with MDS, as often considered a much more indolent disorder, even though it is extremely aggressive in some and can lead to mortality within a year. So MDS pathogenesis is something, it's considered a disease of aging. You're seeing those cytopenias like I was mentioning, but in addition to that, over the aging process, our hematopoietic cells are essentially acquiring predisposing mutations, either based on environmental exposures, problems with correction of normal DNA damage, which is happening in us all the time, which is why we're accumulating over age. And, all of us have some degree of clonal expansion, particularly in the setting of stress. But people over the age of 50 tend to have this more, and each added stressor can cause these MDS initiating cells. Now, these cells on their own are not sufficient to actually lead to the disorder, but acquisition of secondary mutations, epigenetic changes, inflammation, or frankly, just any sort of environmental stressor like radiation or chemotherapy can cause this MDS progenitor to actually turn into true frank malignancy. Now, where these go is many different places. One, like I mentioned, the cytopenias, and secondarily, could be eventually transforming to AML. So again, may not seem like a very aggressive disorder upfront, something that patients are often just like put on supportive care for, but something really important to think of right off the bat. And then the other important thing is to be able to distinguish this from alternate malignancies. So this is another slip up. For example, you need to have the cytopenia, a decisive criteria, which includes dysplasia or abnormalities in the karyotype, and rule out all of the causes that can cause dysplasia. So, dysplasia is considered, there are many masqueraders essentially. So vitamin deficiencies lead to this. Having HIV that's not diagnosed can lead to a clinical picture that looks very much like MDS. Iron or copper deficiency, I very infrequently see people actually checking this. And in the last year, I've seen 2 patients with a copper deficiency alone. So, and alcohol abuse, this is very common and often underdiagnosed. So things to think about, medications that patients are on. So really, first step, I know, everyone, the money is on treatment, but the important thing is to make sure you're truly have the right diagnosis before you start anything. Now, in terms of management, this is a busy slide, but it kind of includes all the key buzzwords that you need to know about standard of care treatment at this point, and I'll walk you through it. So MDS was primarily divided into lower and higher risk disease, and this is based on an IPSS score, or IPSS-R, which is just the revision where they modified, blast count and cytopenias to put them into clinical relevance. And the difference between these groups is that the lower risk groups can actually survive, 5-10 years, but the higher risk groups, their mortality is less than, their survival is less than a year. So very, very different in terms of how they need to be managed. In the lower risk group, you can actually not treat many of these patients and just watch their CBC if they're not particularly symptomatic. But for patients who do have symptoms and a primary cytopenia, treatment depends on that particular cytopenia. And this generally tends to be anemia, which is the most common. So for patients who don't have a clear, driving mutation in this situation, use of erythropoietin stimulating agents is very appropriate. Now, as we've come to learn, in addition to the 10 WHO criteria, having additional information on molecular is very, very important as well. And why this is important is because it helps clarify what to do after we've learned through these sort of easier treatments. So for example, what do we do with a patient with an SF3B1 mutation? Well, there's more recent data with approvals in the last couple of years of a drug called luspatercept that can give you transfusion-free survival for several months when you have this mutation. So important to have that molecular landscape to be able to design your therapy. Similarly, if you have an isolated mutation in deletion 5q, lenalidomide might be a great agent for you because this can actually stave off disease for a couple of years when it works. And then the less common but often consequential are thrombocytopenia, where thrombopoietin agonists can be given, and neutropenia, where at this point actually treatment is not recommended. So something that I see frequently is patients receiving GCSF or growth factors, but frankly, this is not shown ever to improve survival for a patient. So I think the greatest benefit is making sure that they're on the correct antimicrobial prophylaxis. And then the more serious of these disorders, which frequently progress to higher risk disease, is multilineage dysplasia, where you could go to a reduced intensity regimen using hypomethylating agents or ATG and cyclosporin, less commonly used and less efficacious, but this is particularly helpful in patients with hypoplastic MDS. Now, when we progress is often when we get into trouble with these patients, and particularly in the higher risk group, because those patients are getting hypomethylating agents. And after that, the next option is allogeneic transplantation. But what if they are not well for whatever reason? These patients are frequently older, they have comorbidities. What if they cannot tolerate this? This is where area of huge development beyond just on the front end trying to prevent the disease. So again, clinical trials are recommended in this space primarily because we know that after azacitidine has stopped working, median survival is less than 6 months still. And ever since this diagnosis was created about 20 years ago, very little has changed after the approval of azacitidine, which is sad, just similar to Dr. Moskowitz's conversation, where lots of drugs have been trialed and many have failed. So clinical trials have actually shown to be the best options, and some key hot areas at this point are focused on different pathways that we have seen efficacy in or promise in early phase or in vitro in vivo primary studies. So particularly studies that we have at and we're very interested in at this point are using immune modulation. So two drugs that have had really promising phase 2 data are the Cd47 inhibitor, which is basically an inhibitor of the phagocytosis pathway, where you basically turn off the don't eat me signal. So we have a study in this field in particular, and oftentimes because AZA is your standard of care, it's a combination study. Similarly, sabatolimab is another drug that has been looked at, which is a TIM3 inhibitor and hits multiple immune targets. Looking at other pathways, just in heme synthesis, metabolism has been an area we've been very interested in. So we have studies looking at iron metabolism and micronutrient absorption, where we have, an IIT basically looking at patients with TET2 mutations and how can we affect their cancer. Of course, the well-known and more developed area is, using a genomic approach, which I'll talk about more in the AML space because they kind of dovetail with each other. And then other evidence-based doublets and triplets of completely novel pathways, which are less advertised, but very, very key areas of interest. Now, acute myeloid leukemia. Oftentimes this garners a lot of interest because this is very, presents aggressively, and difficult to manage. But essentially you have a block in proliferation as opposed to dysplasia, where it's like just dysplastic cells unable to produce cells. And this leads to accumulation of progenitors and acute manifestations. And, even in this space, as you can see, our history has greatly changed over the last 5 or 7 years, because 7 and 3, which was our standard back in 1973, has remained the reigning champion even to date for young and fit patients in many categories. And it's lamentable that there's this whole 20-year block where there was basically no change in therapies. There are a couple of treatments here which came, made their mark, were withdrawn, and then came back for particular indications, but I think we'll have to, defer that to questions in the interest of time. But how do I think about these newer options? When I'm looking at patients and I'm trying to decide how to treat them, there are 2 ways to think about this. 1, a genomically targeted approach, and 2, an intensity-based approach. So a younger or fitter patient, and I want to be very careful to stress that fit is the criteria, because in these patients, now that allogeneic transplant is becoming more and more accessible for older patients as we know more, and those treatments modalities are improving. If someone is able to tolerate a more intensive approach, you have those prior established regimens like 7 and 3 or FLAG-IDA, but the newer things that have been developed are Vyxeos, which is basically liposomal 7 and 3, and then you have add-ons for gemtuzumab or midostaurin in this to those original regimens in the setting of having a particular mutation or cytogenetic abnormality. And the new category of meds that we have now for AML is essentially oral azacitidine, which is used for patients when they cannot tolerate all the way through intensive therapy, but you have, you have to stop basically early, and it's shown great efficacy and was FDA approved a couple of years ago. Then in the lesser and less intense therapies, we have the development of venetoclax and azacitidine, or Glastigib, which unfortunately was developed at about the same time as venetoclax and tends to have less robust results, which is why it's fallen off a little bit by the wayside. But Glastigib and LDAC was a great option as well. And then in the relapse setting, based on mutations that we have, if you have a FLT3 mutation, gilteritinib is an excellent option. If you have an IDH mutation, these are being tested in the front line, but ivosidenib and enasidenib are excellent options. And then basically, there are other, similar mechanisms in development, but these are the key ones that are currently approved. And how we actually do this. So exactly what I was talking about. For younger or fitter patients, we're thinking based on subdivision. So if they're core binding factor, then we're adding gemtuzumab to intensive therapy. If they have FLT3, we're adding midostaurin. If they have therapy related, there is some data on CPX351. We're not particularly huge fans of it at this institution, and I'm happy to discuss that why later, but there is data to support that. And when they were transplant candidates at the start and then no longer were able to tolerate for whatever reason, oral azacitidine is a great maintenance therapy. In the salvage, as I mentioned, were all of those options, which include molecularly targeted treatment whenever applicable. So the last 5 years, a lot of improvement, but we also have a very long way to go, particularly in people who are non-responders, who don't have a deep response, who have comorbidities, and management has been a challenge with the chemotherapy and the intensity we need to provide to actually get rid of the disease. Elderly patients, because this is a huge part of our population, or patients that have evolved from, MDS, which is also a very difficult situation, drug toxicities, or patients with adverse risk disease, particularly TP53, which has been, the bane of our existence, basically. So in terms of trials, again, looking at this in the exact same approach that we were looking at, how do we do treatment? Well, we have genomically targeted trials, particularly with FLT3 and IDH, and now splicing, which is an area that hasn't been, very successful in the class. So the more advanced in development are the FLT3 BTK inhibitors, or the FLT3 SYK inhibitors, basically. Then in the IDH space, you have your typical, ivosidenib and enasidenib, but we have basically DNA damage repair inhibitors, which have also been something that, I have some preclinical work on, and we're testing now clinically. And then the splicing pathway targeting. So using, sulfonamides, which were found to affect protein degradation in that space. And in terms of intensity, more intense therapies, we've noticed, how can we target those myeloid malignancies more in a focused manner. And so we have basically a CD3, CD123 bispecific antibody. The same mechanism with magrolimab that I talked about in the MDS setting is being also used in the less intense setting for AML. And this is particularly showing efficacy in the TP53 subgroup. So something we're watching very carefully. And then again, in the relapse setting, like I was saying, if it's not genomically targeted in the relapse setting, most of those drugs are being used, again. So this is our group here. I think all of us are pretty approachable and we'll be very happy to answer your questions should things come up. So please feel free to reach out, and thank you all for your attention.
Thank you very much, Dr. Chandok. And that gets us ready for the second poll question, which you prepared for us tonight. A 74-year-old male patient who presents with fatigue and dyspnea upon exertion was told he may have a blood cancer. Peripheral blood labs reveal only pancytopenia. What's the next step in management? A, repeat labs. B, bone marrow biopsy. C, discuss MDS and AML. D, evaluate for clinical trials. Or E, other. Let's wait a few seconds. Let's see how much attention our audience has been.
I'm sure they're going to kill it. It's going to be great.
I think you're probably right. As I said, a mighty group. And I remind everyone, because the Q&A feature has been a little quiet tonight, that you have an opportunity to submit your questions before we tee up our final presenter, because then at the end of that, they will answer all your questions, and it's a unique chance for you to go one-on-one with your peers. All right, Dr. Chandok, how'd they do?
So good. So a majority of people mentioned bone marrow biopsy. And again, I'm stressing this as a very particular point because many patients that I'm seeing in my practice are inappropriately either started on therapy or therapy is withheld because they had the wrong diagnosis. So some people mention repeat labs, and this is a little bit of a trick because you can repeat labs, but if they do have, an extended history of pancytopenia, a bone marrow biopsy is the next step in terms of being clear about what your diagnosis is. A couple of people discuss MDS and AML, and I guess in the setting of this talk, that makes a lot of sense. But in the real world, you're seeing a whole bunch of other disorders. So the one key crucial point I wanted to sort of make today is that do not assume it is one of these. Make sure you have the definitive testing, so that someone with liver failure is not getting, treatment for MDS, a hypomethylating agent, when they don't need it.
Okay, very good, Dr. Chandok. And again, to all of you participating tonight, you have a chance to ask her one-on-one in our Q&A session coming up shortly. But let's prepare our final speaker of the evening, which is Dr. Denise Pereira, a board-certified hematologist and medical oncologist who specializes in stem cell transplant and cellular therapy. She earned her medical degree at the University of Rio de Janeiro in Brazil and completed her residency in internal medicine at the University of Miami. Dr. Pereira went on to complete a Hematology Oncology Fellowship at the Mayo Graduate School of Medicine and an Autologous Bone Marrow Transplant Fellowship at Princess Margaret Hospital in Canada. In 2003, she joined the University of Miami as an assistant professor of clinical medicine in the Division of Hematology Oncology and became the associate director for clinical operations for the stem cell program in 2016. She's now been the president of the University of Miami Hospital and Clinic's medical staff since 2019, and her clinical and research interests are centered on stem cell transplant, cellular therapy, and multiple myeloma. Please welcome Dr. Pereira.
Thank you, Eliana. Thank you all for having me here. I am happy to share with you some of the recent developments that we have witnessed in the field that I practice primarily. Can you see my chart? Yes, my slides?
No, not yet.
It's okay. Let me just make sure that I can share the information. There we go. All right, there it is.
In presentation mode, and we should be good to go. Yes, there you go.
Okay, and there we go.
But it's still not in, there you go. Perfect.
Oh, there we go. The only thing is, which I have to return, I'm just going to get this from the beginning. There we go. Okay, thank you. So as we had discussed before, the title of the presentation is Stem Cell Transplant Cell Therapy, Recent Advance. What I'm hoping to share with you today is some of the new things that have been coming up and that we have been very fortunate to be able to be part of it, creating all this new information at Sylvester, and now having the opportunity to offer the same form of the same information and newer treatments for our patients. So I would like to start by showing this slide that depicts the growth of transplant over the decades in the United States. And you can see that very clearly, both the use of autologous as also allogeneic, being autologous, your own cells, allogeneic, donor cells transplant, have substantially increased over the years. More interesting is that the little decline that you see toward the 1819 actually can be attributed to the coronavirus pandemic, but since then, those numbers have actually seemed to have gone up again. And overall, we are performing as a whole in the United States approximately 20,000 transplants a year, with 8,000 of them about being allogeneic stem cell transplant. Now, the reason why there is such a progressive increase is multifactorial. There are many, many reasons why this has happened, but certainly one of them is attributed to our ability to do older patients. You know, I always like to say that when I started doing this as a fellow, and I like to think it was not too long ago, even though, yes, it was quite 20 years ago, we really didn't have any allogeneic patients in our unit if they were older than the age of 50. Again, I was a fellow around here, and you all can understand what I'm talking when you look at this table. You see, though, that the fastest growing group in a way of, stem cell transplant procedures is the older group, patients over the age of 65. And we know this can be certainly attributed to a multitude of factors again, but more than anything else, a significant improvement on the way that we can support our patients, so support the therapy, but also a very interesting change in modifications on the way that we prepare or we condition those patients to receive the transplant over chemo or radiation treatment that is given immediately before the transplant happens. So certainly this has been a very nice change and have allowed transplant to be more of an option to patients populations that otherwise we wouldn't have done. We have just heard Dr. Chandok discussing with us that certain diseases like AML, for example, are diseases that are primarily of the older patient population. Nevertheless, the changes in access to it is still have not been equal, have not been equal to all. And in reality, what we know is that, there we go, that still to the date, proportionally, there are more white Caucasians that are being offered and can go through a transplant than other minority groups. The reason for this can be many. One can say that access of care can have a substantial impact, but there is something else that I think is very important for us to discuss, and it's something that as a group at Sylvester have paid very close attention. So before we go into that, I will just share with you some of the basics of what we call matching. How do we decide when a patient who requires an allogeneic stem cell transplant being given, with the cells being given a donor, how do we decide who is this donor and if we have an appropriate donor? So in this cartoon, you can see the gentleman here is in the end of a transplant, and in blue, you see the genes that he has inherited from his father. In red, you're going to see the genes that he has inherited from his mother. The only other group of people who have a very similar background of inheriting those pools of genes are his siblings. No wonder why, when the patient comes to us and we are looking for a donor, we are initially always ask for the information about the siblings, and those are the first one that we attempt to type, provided they are full siblings from same parents, in hope that you find a donor, a sibling that would inherit a very similar genetic pool as this patient will. In reality, though, because of the genetic loss, we only have about a 25% chance of this happening. So we might very well, and we'll see this more commonly than not happening nowadays, be left with a patient that does not have a sibling donor, and we're still trying to find someone that can provide this person the life-saving cells that then could be used to restore this patient's bone marrow and allow the patient to be cured. I want to ask you to look into the blue line. This is a line that depicts the number of transplants that have been done over the years with the use of a match-related donor transplant, which is a sibling, as we had just discussed. And you can see that this kind of peaked on 2008, but since then has reduced. And the reason why is families are getting smaller. So in reality, 10 years ago, 15 or 20 years ago, the families tend to be much larger. And for that reason, if you tested enough siblings, you probably were lucky enough to find a donor. Nowadays, we have to fill this void. And the way that we do is by using a group of volunteer donors. They are registered in registry. The United States have its own registry. There are registries in France, Germany, Australia, South American, and so on and so forth. And those are the patients that, the donors that will be tested in attempt to find a match. The very interesting thing to comment also is that this became so disseminated that in 2010, you can see, and depicted this now in orange, being standard for match unrelated donor and mismatch unrelated donor in purple, that this now account for majority of the transplants done in the United States. So if we were to say something, in many places in the United States, right now, you have about twice as many unrelated donors being used in comparison with related donors. The problem is the chance to find a donor is not equal to all. And in fact, as we had mentioned before, as one of the barriers of having minorities having access to transplant and having the procedure, one of the most challenging difficulties that we have found over the years is when we go to the registry, the opportunity for you to find what will fall a full match donor, 8 of 8, as I showed in the cartoon, and 10 or 10, depending on some specifics of the recipient, is a way higher if you're white when you compare if you are an African American or if you're from Hispanic or Latino descendant. And this is very important throughout the United States, but just to reinforce, it is even more important in our very own Miami. So if you look at this slide, you get to the conclusion that in reality, about 65% of the population that we at Sylvester immediately serve, that is the Miami population and other areas in South Florida, there is a disproportional number of patients that would not have access to your standard optimal donor. And this obviously creates a substantial problem for us. Having said that, there is a very interesting information on this slide, which is the following. If we hold to only using 8 out of 8 donors, indeed will be very limited. And primarily, we would be transplanting only patients with Caucasian background. But if somehow we were able to use less than perfect donors, unrelated donors, again, family patients that have no direct relationship with the patients, we would be able to expand this pool to a level that every single patient would then, that require transplant or have indication for transplant, be able to proceed because now we can use a less than optimal donor. So just as a representation, again, in blue, you can see different ethnicities and you can see that Caucasians have a higher chance, but even if you're African American, if we can expand this pool from an 8 out of 8 to a 7 out of 8, we go from only 20% available donors to now you're talking about 70. And if you can go further to 6 of 8, now you're getting very close to 100%. The question is, how do we do that? So this is a model that we adopted here at Sylvester. We want to have a donor for every patient. And our goal is to bridge the gap in access to transplantation using a novel strategy with mismatch unrelated donors. This is a study that we were part of it, and I'm very proud to say we were the center with the highest number of patients enrolled. Those were patients primarily from South Florida, but some of the patients, international patients, that also would have difficulties finding donors on their own home city or home country. And this study looked into a novel way of doing a transplant. So traditionally, the way that a patient, the process goes is once the cells from the donor having been secured, the patient is admitted, get chemotherapy that is used to prepare for both destruction of the cancer cells, but also to suppress the patient enough to receive the cells. Once the chemotherapy is finished, the cells are infused, and then you go from there with the transplant as supposed to be with, a lot of supportive therapy, antimicrobials, and some degree of immunosuppression. Now, what this study does differently is use cyclophosphamide after the patient has already received the donor cells. So they get the regular standard chemo before, but they get also 2 doses of high dose of cyclophosphamide after. And that work in a way of depleting some of the T cells from the donor and allowing for an improved tolerance between both the donor and the immune system of the recipient. You can see that on this study, majority of patients, no surprise, were patients who were from other ethnicities that were not white. And the reason is because those were for patients that we could not find the so-called ideal donor. What we were able to see is that the patients did indeed have pretty much all of the patients enrolled were able to transplant, or we were able to find a donor. But even more encouraging, this is the result. At the end of 1 year, this group of patients that otherwise could not be done using standard form of transplantation now have an overall survival of approximately have an overall survival of approximately 75% at 1 year. So the conclusion of those studies, which was again an initial study, was that this approach is feasible and is safe, and does offer similar outcomes that compared to other platforms that use more restricted donor choices, 10 out of 10s, if you will. Actually, 48% of the patients enrolled were from minority groups. So by all means, this really afford the ability of us to do patients that otherwise would not have a donor, an appropriate donor for. And based on these studies, we at Sylvester are in conjunction with other centers conducting a larger study to confirm those findings. I'm happy to say that one of my colleagues, Dr. Jimenez, is the principal investigator and the one who spearheaded this larger trial that is currently being conducted. Also of interest is knowing what we know, that once we found out that we can really do this, we start even off study to offer this to patients. And really it translated within a substantial change of our practices. Specifically nowadays, what we do is 1/3 is unrelated donors. I'm sorry, 1/3 is related donors, siblings. The other third is perfectly matched unrelated donors, but about 1/3 what we do already are patients just like that otherwise you could not find a proper donor. We actually looked in our own data to see how these people did, the ones that had less than perfect donors, with the old way of doing transplants. And on the next slide, you can see in red that both the overall survival is a way superior and very close to what you saw on the study. This is our actually, our real world data with all patient comments, people are in and out of the study, compared to the old way of doing, which was using ATG, much better in results. But not only that, also the mortality associated with the transplant, is a way lower with the use of this new platform. So we are very, very excited, very proud also to be able to offer to the South Florida population, but also to many other places that finding a donor might be difficult because of the genetic makeup of the population, the opportunity to have a donor where otherwise patients would have been excluded for at least a life-saving procedure. So I am now going to change gears and talk a little bit about something else that is very exciting that we have the opportunity to offer at Sylvester. We also were part of one of the studies that was associated with the second cell therapy to be approved in the United States, which is Carty cell therapy. I'm going to tell you a little bit. This is a cartoon that depicts how this works. Bear with me. I'm going to try to explain the steps. This is a form of therapy. They use the patients, at least for now, and we're going to talk about that later, the patient's own T cells that go to be modified to then recognize the cancer and engage and kill the cancer. And how is this done? This is done by initially removing through a procedure called apheresis the patient's own T cells. Those T cells are then sent to a manufacturing plant, a laboratory that will work to insert a gene for a chimeric antigen receptor into the patient's T cell. This chimeric antigen receptor is specific for a protein that the cancer that you want to target would express. And once this is incorporated and then read, the patient T cells have now the ability to express this receptor. Once you get to this stage, those cells are then grown in the laboratory until you achieve a minimal number what would allow you to proceed with the treatment. At that point, the manufacturing plant call us and say, we have your cells, they are ready. Patient comes, see us, we confirm once again that the patient is in good condition and we can move forward with the treatment. And right here, and I know this cartoon is missing one piece of information. The patient gets what we call lympho-depleting chemotherapy, which is when you give a chemotherapy that would eliminate the patient T cells, so you can create space for those new ones that have been produced and will be reinfused. Once lympho-depleting chemotherapy is concluded, the patient receives the CAR-T cell. And then after that, the CAR-T cells will proliferate further and engage on the tumor cells. And as a final result, hopefully kill the cells and cure the patient, which will be the ultimate goal. So this is a little bit close up of the picture that we saw. You can see here the CAR-T cell that has been engineered and reinfused has this receptor that then recognizes the CD19. And in Dr. Moskowitz's honor, this is a lymphoma cell, Dr. Moskowitz. And we are expecting that with this interaction, the CAR-T cell will kill the cancer cell, by large, sparing health cells, if you will. The interesting thing is, once you get CAR-T cell therapy, it's different than getting chemotherapy, because once you get chemo, you give one dose, and to continue with the effect, you need to get subsequent doses. This is different. When you get the CAR-T cell, you give the CAR-T cell right here, but then they would expand on the patient's body. And it does so, there is a continued effect on killing the cancer cells. And in fact, we would hope so in preventing relapse, because you still have the CAR-T, even though you don't have the cancer cells here anymore. This is the study that I had mentioned that we participate on. This ultimately led to the approval of the first CAR-T approved for diffuse large B-cell lymphoma. We did treat our patient, and you see some of the slides showing some PET scan on that particular patient. The first patient was treated in January 2016. As a result of us being very familiar with this product, we also were one of the first 18 centers in the United States allowed to commercially use this product. And this was in 2017. So this is the first patient that we treated, Sylvester, that was enrolled in the trial that we just talked about it, 59 years old female. At the time that she arrived to us, she had had multiple lines of chemotherapy. You can see them listed here. At that time, really, there's not a lot of options available, and the patients were given multiple options, but primarily clinical trials or hospice. And we had, at that point, just opened our clinical trial on Carty, and she was enrolled. So this is a temporal depiction of the patient's PET scans. Here, December 2015 is the patient baseline. You can see that the brain picks up. Usually the heart is right behind here, picks up. You can see kidney picking up a little bit, but all this darker area are areas of disease. And this is December 2015. Patient was provided therapy in January 2016. And this is the scan, the follow 1 month later on a patient with 4 prior lines of therapy and just not responding until then. And this is a follow-up scan done 3 months later. So as a result, many other patients enroll after that, and the cell therapy was ultimately approved. Having said that, this is a form of therapy that is not without substantial side effects. And I have listed some of them for you here. CRS, cytokine release syndrome, that really resemble a septic syndrome. The other one that we call ICANS, immune effector cell-associated neurotoxicity, that goes anywhere from difficult recognizing some objects, being able to name them, all the way to seizures, and even on very rare events, death, if you will. In a way that is not immediately seen, but that we have been able to observe, and actually our group was one of the first to report, prolonged cytopenias after this form of treatment have been reported. And also HLA is a very rare complication, but again, we have seen it. Besides that, because of when you use CD19 driven, CD19 target, once you're removing also some of memory B cells, you can see a prolonged hypogammaglobulinemia with a susceptibility to infections on those patients. We have right now at Sylvester treated a total of about 150 of those patients. Of those 150, I'm very proud to say that 50 have been on clinical trials. We still have, and we're going to talk a little bit about additional trials with this within this form of therapy open. And we can definitely see that the number of patients is picking up. As of last month, we have treated 9 patients with Carty cell therapy at Sylvester. And at this month, it looks like it will be very similar numbers, if you will. Just a brief comment, why do we tend to admit those patients for a short period of time? Because once the patient receives the infusion, as the Carty cell expand, that's the time of the higher risk for this more severe and initial complications. And usually we keep the patient at least 7 days, but at times longer. As more Carties are made available and less toxic ones are done, the possibility of doing this in outpatient exists. In fact, we have done those at Sylvester already, but depending on the product that you have and how likely it is for the patient to develop CRS or neurological symptoms, we really still tend to admit the patient for approximately a week, if you will. I have just listed here what are the diseases and the current indications that have Carty cells approved in the United States. I'm happy to report that we have at Sylvester pretty much all of them available. The myeloma ones, which are listed here on the bottle, are harder to get because they have just come to the market. And in reality, they have been facing some production issues. And unfortunately, there is a waiting list. Other products that have been here for longer or diseases like lymphoma, specifically mantle cell, diffuse large B cell, and follicular lymphoma, we really don't have an issue once the patient does qualify and the insurance is approved and the patient go through the pre-screening and all the tests checked right, we're really able to treat those patients within a relatively short period of time. So this is, again, like a summary of what we currently have available, not only in the United States, but at Sylvester. Having said that, some of the patients and some of my lymphoma colleagues will attest to that. By the time that they come to us, they have failed some lines of
Denise,
therapy.
you got to finish up a little bit, okay?
Okay,
We're
no problem.
almost out of time.
No problem. Almost last slide here. Actually, 2 slides. So in hope to decrease the time they take from the stem cell, not the stem cell, sorry, for the Carty to be, the T cells to be collected and the Carty to be produced, which usually take a 3 weeks amount of time and is enough time for some of those patients to deteriorate. We're currently offering this study where allo Carty have been produced, meaning that the Carty has been produced using a donor cell. And when a patient comes, and this is all in the clinical study, the patient can be offered almost immediately therapy. The average time to treat those patients once they enroll in the study is less than a week. So this is something that my colleague Lázaro Lakakis is spearheading and is currently available at Sylvester. With all of that, I will conclude my presentation. This is actually one of the patients on the study. You can see again all the dots. And right now, patient after treated with this allo Carty, a normal PET CT. So with that, I will conclude my presentation. And I thank you so much for your attention.
I think you're muted, Elena.
Ileana, we think you might be muted.
You're on mute. Nope. No, you're not coming through, Elena.
Okay, Dr. Moskowitz, this is Luciano. Why don't you kind of like wrap
I
up
will. I'll say something. Yeah.
the session?
So anyway, I want to thank everybody for joining the session. I certainly learned a lot. We still have a long ways to go. You know, I would say muted optimism. You know, Denise only shows the good things, which is good. Namrata shows the bad things, which is
Realistic.
not so good. I show stuff somewhere in the middle. But at the end, I think that we have to remember that hematologic cancer is very, it's unique. There's sophistication involved. My strongest recommendation that I can make on any patient who is seeking our advice, it's critical to get expert pathology review on your case. You just saw, just from Dr. Chandok's presentation, there's a laundry list of things that this can be. And those pathologists have to have significant experience to differentiate some. So I urge you to always get a second opinion on a life-threatening disease that is potentially curable. We're happy to help. You can always email any of us, and we're happy to see your patient or give you advice. I answer everybody by email, whether I know them or not. We want to move the field forward. So thanks everybody for your attention, and we're always happy to do this again at another time. Have fun. Have a nice night, everybody.
Thank you.
Bye-bye.
Bye-bye.